El papel que tenemos la gente necesita, es un poco... Poi occupava solo il centro della sala. Sta muy bien, ¿viste? Más o menos el centro de la sala. Ciao, Scioli, come stai? Sono felice di vederti in gamba.
Sto switchando un po' il cartello e...
Dobbiamo... Te le faccio quelli tagliati.
Hello and welcome to our guests and friends here at the University of the Holy Cross in Rome, and to those of you who are following us live on the English YouTube channel of Rome Reports. This event is sponsored by the SOMOS Community Care, together with Rome Reports television news agency, and in collaboration with Harembee, Africa, with Caritas Internationalis, and the Pontifical University of the Holy Cross. Thank you for choosing to participate in this event and to share in a conversation that really is of vital importance to all of us, whoever we are and wherever we are. I'm Seàn-Patrick Lovett, and it's my privilege to act as moderator of this panel discussion, which we've called Vaccines for Everyone from Words to Actions. I don't think the title needs much explanation. The numbers say it all. 55% of people in affluent nations are fully vaccinated, as opposed to around 1% of people in less affluent countries. It's our hope that by the end of this roughly hour-long meeting, you too will want to encourage greater international solidarity and cooperation in the distribution of vaccines and in providing health care to people who are most vulnerable and in need. Our panel includes the heads of some organizations that are not simply talking about the problem, they're already putting words into actions, helping vulnerable people on the ground, not just in developing countries, but in the peripheries of the world's wealthiest nations as well. It's an honor and a pleasure to welcome you. Thank you for being here. We're going to begin with Father Christian Mendoza. He's Associate Professor of Catholic Social Doctrine at the School of Theology here at the Pontifical University of the Holy Cross. And that's really why we've asked him to open the discussion today, to set the topic in a broader moral context, to help us understand what Catholic social teaching says about the obligation to care for our own health and for the health of others. Father Christian.
Thank you very much, Seàn-Patrick. Thank you, everybody, for being here today in this event. It's a big honor for me to be here with you, hosting this event at the Pontifical University of the Holy Cross. The Church teaches very clearly that we have the obligation to take care of our life and physical health. The sources of this teaching are the Catechism of the Catholic Church and Evangelium Vitae, a letter written by John Paul II. There, it stems very clearly that life and physical health are human goods. And as human goods, they come back to men. So if we take care of them, we are taking care of ourselves. But there are two conditions, as the Catechism says: life and physical health are precious gifts entrusted to us by God. We must take care, reasonable care of them, taking into account the needs of others and the common good. So I will focus only on those two things, taking into account the needs of others and the common good. If we speak about the needs of others, imagine a family that has little children. They have to take care of their health. Even if they don't like to have medicine because it tastes bad, they have to eat the medicine. And so when someone doesn't have the formation or the information to take care of his own health, someone has to help them. Once that a family has already the capacity to leave their children under their own decision to see what's the best mean to take care of this, then they're free to decide. But then also the common good, and it's the political authority who are those in charge of the common good. So if you want to visit some African countries, you need to have a yellow fever vaccination. If you don't want to have the yellow fever vaccination, you will not be allowed to get in. And it is not because they don't want you to get there. The problem is that they are taking care of your health because the political authority has the responsibility on the common good. Now, the problem with the current pandemic is that the virus is coming to us. We are not going to it. Now, when this happens, then there are three big considerations that the Church is giving us to think about. First, information. The political authority who takes care of the common good and the families who take care of the health of others should have enough information. If I decide not to go with the legitimate authority when they suggest a mean to take care of my health, I should have better information. If I don't have enough or better information, so maybe I could fall in an injustice with my family and with the people around me because I have to take care of the common good of others. Second, the first one is information, the second one is the means. Not every mean is good for everybody. Some means to take care of my life and health could be bad for me or my family. And there's also a way to take care of my health that should respond to what I believe as the greater good. So once that I have enough information and I know a series of means to choose, I have to understand what is the greater good I want to pursue. Because I can order the means according to the good I want. I maybe should decide not to eat something that everybody likes as a mean to get nutrition, but I choose this other mean because I believe that it's better not to eat certain food. So there's an order of the goods. Not every mean is good for everybody. Saying this, and because I don't have a lot of time, I would just remember that the Congregation for the Doctrine of the Faith said that vaccination against coronavirus is not as a rule a moral obligation, so it should be voluntary. It is also true that the legitimate authority is indicating this vaccination as the best mean to take care of our own health and the health of others. The political authorities are taking care of the common good using this mean. So, how can we make a judgment about the current situation if we follow what the Church is teaching? First, that we should go and look for the best information available. Second, that it is good to understand which are the best means to choose. Third, to think about what is the good that we pursue. And if we don't know clearly which good could be damaged by using or not using vaccination, then we will not be ready to go against what the legitimate authority is saying. At the end, the Church welcomes all efforts to provide those most in need with medical services. That could be vaccines, or it could be other means. And the Church encourages everybody who wants to take care of this human good, that is life and physical health. Thank you very much.
Thank you very much indeed, Father Christian Mendoza. Yes, seeking the best information, identifying the best means, and pursuing the common and greater good. That's the broader moral context from which we're beginning our discussion today, a discussion that will be picked up by our next guest on the panel. You will see from the invitation that at this point we should have been hearing from Dr. Aloysius John, who is Secretary General of Caritas Internationalis, but Dr. Aloysius John was called away to a meeting in the Vatican this afternoon, and so hence sends his apologies. But he also sends Dr. Maria Amparo Alonso Escobar to stand in for him. She's head of advocacy and campaigns for Caritas Internationalis. As my journalist friends will know, Caritas Internationalis is a confederation of over 160 members that coordinates emergency operations and formulates development policies all over the world. Dr. Maria Amparo Alonso Escobar headed the Caritas delegation at the United Nations in Geneva. She's here today to give us some examples of the challenges and the needs and how to translate ideas into concrete actions, especially towards those most in need. Dr. Maria Amparo Alonso Escobar.
Thank you very much for inviting me to participate at this important meeting. Yes, I think when thinking about the access to vaccines, we we are in front, actually, of a global security problem with many dimensions. Actually, health, social, economic. We have consulted the whole Confederation of Caritas Internationalis, those 162 members in 200 countries, and we have asked them exactly which are the challenges that your country faces in dealing with the access to vaccines, which are the bottlenecks, and which are the actions, the advocacy actions that you would like us to call for in order to improve the access to vaccines in the world. And there are different elements highlighted by our confederation, so I'm speaking, bringing this global contribution from the global confederation. One element they have highlighted is important to ensure effective vaccine administration within each territory. As you know, the World Health Organization set up a mechanism which is called COVAX, Act Accelerator, and this is an important mechanism actually for those countries without the power to negotiate directly, as it happened at the beginning, no? That those with the power to negotiate, they got the vaccines earlier than the others. So it's important, this mechanism, but this mechanism arrives to the border. So what is happening with the most vulnerable people, what is happening with the most vulnerable people living in rural areas, rural communities, more marginalized? What is happening with the peripheria, as Pope Francis is always speaking about? Second recommendation, partner with faith-based organizations. What is happening that in least income countries, the Catholic Church is working so closely, delivering health services to most vulnerable in some countries as DRC. I had the chance to work for Africa during 15 years, where I witnessed this work of the Catholic Church, not only for Catholics, it's for the whole community, rural communities. They don't ask, are you a Catholic? Is without any distinction of creed and religion, but they are there closing and giving services in some countries, as in DRC, to more than 60% of the total population of the country. So one second recommendation, partner with faith-based organizations, because they are close, they know, they listen, they accompany the most vulnerable people. Third recommendation, share more vaccines doses with least income countries. We have political commitments. G7 just happened some months ago, and only 10% of the doses have been really delivered out of that meeting. And we are welcoming the G20 Leader Summit in Rome. So this is an occasion to invite the states to take a strong and global leadership in funding, sharing, and distributing the vaccines equitable. Also, provide additional funding and support to this Act Accelerator mechanism, as we think is important for those countries without that capacity to negotiate. Of course, another recommendation is to increase manufacturing capacity for vaccines globally. You know, there is a barrier to produce the vaccine locally, which is important in complement to this Act Accelerator, is the capacity of the countries to produce the vaccines locally. This is also ensuring technology, the know-how transfer. But we are facing a barrier, which is around the intellectual property rights. And right now, there is a political dimension around this, and there are two political positions, one in favor, the other group of countries against this because of business reasons. So let's put people first before business, because this situation deserves a human rights-centered approach. Then continuing strengthening health systems while distributing vaccines. Why? Because we have also those who had the chance to accompany African countries, and in my case, during 15 years, we have seen how the health systems were before even the pandemic, and now how those health systems have totally collapsed because of the pandemic. So it's not only to distribute the vaccines, it's how also to adopt a comprehensive vaccination policy and public engagement campaigns, adapted, of course, to the local context. And then finally, the richer countries should leverage diplomatic, economic assistance to ensure the inclusion of most vulnerable, those at the periferia, those rural communities, those refugees and migrants, those IDPs, those street children, those homeless people, people with disabilities and so on, into the vaccines scheme, because this is one of the facts brought by our Confederation. In all the regions, Latin America, Asia, Africa, they had highlighted at the end that those without the possibility to get access to the vaccines, for one reason or the other, has been the most vulnerable people. So let's put again back the people at the center, and the most vulnerable in this case. Thank you.
Thank you, Dr. Maria Amparo Alonso Escobar. That list that we just heard of vulnerable people is again a confirmation of how much Caritas Internationalis really does have its finger on the pulse, so to speak, even and especially in the peripheries. And we can never get tired of hearing that phrase, people's needs before business interests. So thank you for that. Dr. Linda Corbi is project manager of Harembee, Africa. Harembee is a non-profit communication, solidarity, and development project present in 21 African countries, including Nigeria, Ivory Coast, and the Democratic Republic of Congo. Dr. Linda Corbi describes herself as, and I quote, and watch her smile because she doesn't know I'm going to say this. I read it in an interview that she did some time ago. She describes herself not as a missionary and not as a businesswoman, but as someone who loves Africa. And that's why Africa is at the focus of her presentation. Over to you.
Thanks for quoting that interview. Everybody, good evening, everybody. Now, Harembee. Harembee means altogether in Swahili, it's a Wili word. And during COVID epidemic, our help went to 3 centers that have been our partner in Nigeria, in Ivory Coast and Congo. Today, there are numerous hypotheses, like I won't show you. I won't go through the slides because time is matter of time. And here are the numerous hypotheses about this phenomenon in Africa, but it's still being studied. So nobody knows why the incidence of COVID was lower than in other continents. Today, according to the World Health Organization, African population has received only 1.4% of COVID vaccine doses and 2.2 billion doses distributed worldwide. Considering that Africa is populated by 1.3 billion people, representing 16% of the world's population, the goal of vaccinating 60% by 2022, as affirmed in Pretoria meeting last June, is not likely at all. Let's see, next. Here you see. As of 6 June, Africa had about 6 million infections, about 4 million recovered, and 131,000 deaths linked to COVID, which is considerably low compared to Europe. COVAX aimed to provide Africa with 600 million doses, enough to vaccinate at least the 20% of the population. However, it's very slow in Africa due to a number of interacting factors. First, there is a clear financing deficit on the part of governments, the systemic weakness of the continent's health system. The supply chain is in many cases defective. Undefined criteria to ensure the most vulnerable population have the vaccine soon. Moreover, international interest in Africa should be motivated by the fact that if left to its own devices, this continent could become a giant hotbed for variants of the coronavirus. As underlined by the report commissioned by WHO and published last May, it's clear that high-income countries should commit to provide at least 1 billion doses of vaccine to 92 low- and middle-income countries, such as those in Africa, by September, and more than 2 million doses by mid-2022. At the same time, major vaccine-producing countries and companies should come together under WHO and World Trade Organization to agree on licensing, production, and technology transfer so as to tackle any further virus mutation in Africa. We all know that COVID pandemic took our world by surprise. Moreover, Africa has experienced epidemics, so WHO directives immediately implemented measures such as medical and paramedical staff protection, all of this we know it well. And also government selected a number of health centers for COVID testing and treatment to limit contagion. It led to crowding in hospitals that had to reject people, long queues for tests, and serious delays in delivering results. Consequently, people turned into other health centers, creating many problems. In the case of Wale, one of our partners located in Yamoussoukro and Ivory Coast, it's a small health clinic, totally unprepared for COVID patients. Harembee here provided detective kits for staff, a prefabricated building for patients of COVID and infectious disease, and a car to start a home care program to prevent ill patients from moving around. Here again, COVID demonstrated the limit of health system in terms of unspread staff, unprepared staff, delays in delivering a result, crowding of patients, among others. As far as I know, there are only 4 or 5 intensive care units, ICU, functioning in the country. Nigeria. In Nigeria, Harembee collaborates with Niger Hospital, which is not a referral hospital for COVID, but has taken in patients and carried out tests on the population of Enugu City for its good analysis laboratory. Harembee also contributed to the purchase of protective measures for the staff, and now are planning to buy additional laboratory equipment, ventilators, and set up an oxygen production plant. In Nigeria, it's difficult to know the real number of people infected because people hide their symptoms so as not to be isolated from the families. There is a common attitude of skepticism, mistrust of institutions, and fear of the consequences of the vaccine in long term. In fact, life is carried out normally. The pandemic hasn't worried the population too much. The third healthcare center we are supporting is Monkole Hospital in Congo. Here we are. The hospital received the manager of the Congolese Ministry of Health as inpatient. He was really infected, in critical condition, who, when recovered, appointed Monkole as a COVID referral hospital and promised financial support for the hospital's expenses. However, the government funding has been slow, and the hospital had to renovate a building for COVID treatment. Consumable equipment had been purchased, but much of which should have been donated by the government. Also, during peak infection period, additional medical and paramedical staff were hired at extra cost and much inconveniences. The training of external staff was not always adequate, and teamwork had to be replanned. A European volunteer doctor said that, for example, no one knew how to intubate a patient. There are no or very few intensive care units in the hospital in Congo, and the whole country has only 10 respirators, all concentrated in Kinshasa, and acquiring more has a very high cost. The current priority is to modernize and upgrade the oxygen supply system for the hospital and for the other hospitals of the country. In regard of the vaccines, it has not to be optimal due to the delays and disorganization. In some cases, some vaccines have not been used, or doses have been delivered at the limit of their expire date. Look at the last 2 lines, please. The number of doses they received and how much they actually gave to the people. Here, the tips and information to citizens has been very poor and unconvincing. The president himself said he never would have been vaccinated, but he did going abroad. And the population was left with the idea that vaccination was useless. On the other hand, the economy is a bigger issue for people. Small business and markets have been banned. Schools have been closed, leaving children alone in the street. The bigger emergency for people is poverty, the lack of work, hunger more than COVID, which is lesser threat than other diseases such as malaria, HIV, TB, etc. So, to summarize this experience, the support we have provided to health center has changed from an emergency aid linked to COVID to a program of help to improve local health service. All the resources have been brought to bear on COVID could be a start to a joint effort to tackle any future epidemics with adequate information, means, and professionalism. On the African continent, there is a substantial presence of international organizations working in close contact with population, even in these remote areas. These have local community trust, which is why it would be very effective to be acquainted with them and work together to reach the common goal of good health service for all. Thank you.
Thank you. Thank you very much, Dr. Linda Corbi. When I read on the program that you would be addressing the vaccine issue in Africa, I was a little concerned because it's such a huge area. There are 54 countries in Africa. The situation is varied and complex, but the fact that Harembee is present in nearly half of those does give us at least a glimpse of the complexity of the issues. And thank you very much for the PowerPoint, because I think seeing the numbers also is hugely effective and kind of helps us to really get the sense of how broad and difficult the issue is. Our final guest on the podium, there he is. His name is Dr. Ramón Tallaj. He is chairman of SOMOS Community Care. SOMOS is a healthcare company that Dr. Tallaj founded in 2015. It comprises a network of nearly 3,500 healthcare providers and has delivered close to 2 million vaccines to minority communities, to mostly minority communities in New York City. Dr. Ramón Tallaj would have been the Dominican Republic's Minister of Health if he hadn't accepted Cardinal Timothy Dolan's invitation to assist in providing health care to New York's underserved Hispanic immigrants. Just for the record, Dr. Tallaj himself remembers growing up in poverty and having to study for his medical exams by candlelight. He's also on the record as saying that despite being a grandfather of 5, he still has plenty of projects in mind, both as, and I quote, a doctor and as a human being. I really hope he'll tell us something about those projects right now. Dr. Ramón Tallaj.
Thank you. I will try to make a different perspective that you had here today about what happened in New York. You allow me to. We have a community physician. We are no hospital. We'll take care of the poor people, as you mentioned, the amount of people in New York City that actually are in poverty line, what they call it, and they have the insurance called Medicaid. And the majority are essential workers. I mean, they can't stop because they have no money, they stop, they don't eat. And we live in small apartments and buildings that 11, 12 people in one bathroom, one bedroom. Therefore, you understand that so many people die in our community because the way that we were living already with 3 generations, and also that poor health that we get for this inequality that exists before. They just put it more by far, to put the point that 60% of the deaths, 68% is between the African American, Hispanic, and Chinese during New York City. And this is the scene that I want to make something. The amount of tests positive does not reflect reality, because rich countries have more tests to do, poor countries have no money to spend for tests. Deaths is real. That's real. People in hospital suffering is real. Sequelas are real. But number of tests positive, that will depend how much money you have in order to produce tests or create tests. My country was more prepared for an atomic war. We had warheads to kill people, to save us, than to have PPE to save us from the virus. That happened. It's already there. But saying so, United States was very big in having vaccine. But we had challenges, especially in poor communities like ours. The first challenge is to have the vaccine. We have it. The second are the equipment. You have to have the freezers. We had the change. Then you have to have personnel. We did that. We were perhaps the number one doing this in New York. And the trust, that's different, the trust. In our country, there's not much trust in politicians. Therefore, we, from the beginning, being doctors, made alliance with the churches, with the schools, that the people will trust. We did a poll, clearly. 10% believe in politicians, 70% in doctors or priests or the teachers or professors. Therefore, our success was that. But not only that, we met the people in their places. We opened testing sites, yes, with the government, Yankee Stadium, Aqueduct Racetrack, many universities, but also we demand vaccine for all our practices. If you have more than 1 million patients in the community and they trust, they believe in you, the logical thing is give it to them. Not because of the show to vaccine by massive people. We did it there, but we did it in our practice to request that. Now, I really believe that every single person, almost everybody, is going to find the virus, sooner or later. How do you want the virus to find you? With vaccination or without vaccination? And that's our way to attract young people who believe that nothing will happen to them, especially when this virus changed so much. It's 4 times. And I call this virus the solitude virus. And the only hope is the vaccine of hope to take care of that. Now, this is our mission. In New York, after we did all of this, we were able to vaccine millions of people. But then young people didn't want to get vaccine. What we did, we also have resources. We went and make it with Marvel and the comic books, the Avengers. And told them we create 20,000 comic books, we could have 40,000. Kids, young kids, in less than a week, 7,000 show up to get the vaccine because they want a collection collectively. Then you have to be invented. Yes, it's going to happen probably in Africa because it's difficult to get that. But I'm talking about what happened in New York. How do we try to approach the people? Because the reality is we were the one who died the most. We were the one who got more sequela than anybody. I have 4 children who suffered the disease, all doctors. And one of them almost died. I mean, I've seen that. But the most important part to attract the people to get the vaccine, after you have all, you have it, you have the equipment, you have the personnel, you have to go to them, to meet them where they are. Train station, let's put it there. Is they have to work, wherever they go to work, find a way. You have to be in this world that so many things have happened in poor communities, like the Hispanic, African American, in the past. Scare tactics has been used very heavily to avoid them to get the vaccine, while other ethnic groups were getting the vaccine easy. And this is the way that I see this problematic is because we had to meet the people in their places. You cannot lie down and wait. And this is what, as Mario said, we had done 2 million meals, more than 1.8 testing, and by far more than 1.5 vaccine, using our own resources, not being reimbursed. Poor doctors, communities, we put on the line 25% of resources in the bank to do this in our community because we've realized nobody will come to help us. And the last part I want to mention to you is that the vaccine, the same way that we identify a new virus, is so easy. About science now. Easy, no? It's a computer who tell you it change here or there. I imagine that the same way is easy to the same computer, hit a button and tell you how much you have to change that to be able to create a vaccine who will attack this new one. The problem is we are by far more advanced in this computer system to identify than the protocols that we have still today to develop vaccine and put into place to be used to save people's lives during the pandemic. We have to wait months of this practice, months of this review, months of this tabulation, months of this result. While some people also want to get the vaccine, I'm saying, my God, we should be having a new vaccine with the 4 variants out there attacking them. because reality, the whole world had to put together to come and give the vaccine. Yes, it's going to be people skeptic, but why are we here? We have a 70 years old, 80 years old, 50 years old. Why are they still alive? Antibiotics, vaccine, these are the advances in medicine. Now we are doing that, but also in the holistic way, saying these things for us. It comes from taking care of the poor, feed the hungry, care and cure the ill, and treat the other ones the same way we would like to be treated. We haven't failed doing that. And this is what our mission is in New York City. And now we are going to Cuba, we're going to Dominican Republic and Haiti. We're trying to do the same as we did in other states. And I hope that gives you an idea what I've been through, because most of the deaths, most of the sequelae are still in our community, essential workers. Sometimes you cannot find a body inside a truck. We have to put millions of dollars ourselves to be able to bury those people without documents because their family members doesn't want to show up. It could be deported. All these things that you had to live, we have been through. Thank you.
Thank you, Dr. Ramón Tallaj, for that reality check and for reminding us that the issue is not just in developing countries, but in a developed country and in one of the so-called most developed and wealthiest cities in the world. That scare tactics don't always work, but that we do need to be creative, and that catchphrase, which is of course a phrase of Pope Francis too, isn't it? Going out and meeting people where they are. I think this is the point where we open the discussion to the floor, as we say in panel discussions. If you have questions for any members of our panel, if you do, please put up your hand, identify yourself, and identify the person to whom you are addressing the question. And also, please remember that brevity is second only to sanctity. I have, who is first? I saw Javier, Rome Reports, please, go ahead.
No, thank you very much for interventions. Also, the same question to the doctor, or maybe also you can tell us here, you Maria Amparo Alonso. No, here in Europe, they are insisting very much in the fact that the vaccines should be for everyone, but should be mandatory. Christian has put example also with the federal job. And of course, they should be mandatory. And this is, but how is the situation in the US, Doctor? When they do it mandatory, there are some people that cannot really need to receive the vaccine. I mean, what is the limit between the public health and the taking measures against the ones who doesn't take the vaccines?
Who would, I think anyone on the panel could open up, but you were specifically called upon, Father Christian, so go ahead.
Thank you very much, Javier. I think on the one hand, you can distinguish between what is the civil obligation that the government is telling you this is mandatory. You should have or you must have the vaccine. And if the government does that, the legislation should also include the exceptions. Because some people cannot have the vaccine because of their medical conditions, for example, or because many other reasons that the government should address. And this is a legal obligation that the church has nothing to do in the sense that this is something that belongs to the government responsibility. Well, now, if you speak about like the moral obligation, this gets very tricky, because what is a moral obligation? The church teaches that moral obligation is something that is on conscience, and it is somehow written in the heart of man. So I understand that due to the conditions of society, of my health and the health of others, of what's happening now, I may have the moral obligation to use the vaccine, but the moral obligation is always voluntary. The church teaches that the greatest moral obligation is to love God, which is voluntary. So at the end, no one can force you to have a mean to take care of your health, but you should not act without information and deep thought, and also, I would say, an answering conscience about what you're doing. This is the question, I think.
Did someone else want to add anything to that? It's a key question, so if someone else wanted to add anything. Yes, please, go ahead, Maria.
Yeah, to complement to that, I think this is a strong dilemma, especially in developed countries, because in developing countries, they are lacking actually doses of vaccines. So depending on how, on where you position yourself, in your community only, in your country only, this is my only country, and this is, or you also look at the whole world, and the whole world says to us that they don't have that privilege to think about mandatory or not, because actually, just to give you examples, where in Tajikistan, for example, the government asks for payment, and then those most vulnerable, they don't have that dilemma, they don't get access. So depends on where you position also yourself to ask to that question as well.
Please go ahead, Dr. Ramón.
The reality is, practically, you see it. You can't force people. It's happening. It doesn't matter if they say yes or no. It will be people who will die before they get a vaccine. That's real. And it's still there, even in different types of countries. Totalitarianism or kind of free country, whatever you're going to call it. People say no. We just came from Cuba. And still 40% of the people hasn't get it in some places like La Habana, because a lot of people say no. And they have vaccine for the other places that want the vaccine, they don't have it. I mean, it changed. And you cannot force people, doesn't matter what. Yes, tuberculosis, if you have it, you lock out. It doesn't matter in the United States, you want it or no, you get into a room to be isolated. If you want to go to school and you don't have the measles, you must present, otherwise you can't go to. I mean, there's nothing new. There's certain things you cannot get in or you cannot participate if you don't have those papers.
There was a question over here on this side of the room earlier on.
My name is Ramón Tallaj. Basically, I have two questions. One,
where are you from?
Oh, from Nigeria.
Thank you very much.
Thank you, sorry. All right. So I have two questions. First is more of questions from my friends, which I want to reflect, and then the second mine. So basically, my friends have been asking, why so much distrust in COVID-19? Specifically, there have been, which I don't want to believe, but there have been rumors that the vaccines sent to Africa, or specifically Nigeria, are not exactly the same with what is being used in other countries. So there's this question, and how do you confirm the viability of the vaccines being sent to Africa? This is part of the reason why some persons or friends have told me that it's questionable, that HIV and AIDS, Ebola, cholera, for instance, no one fights to dispute that these things are real. But with all the deaths, why is this still in question? So the first question is, why so much distrust in the whole COVID issue? Now the second is mine. I want to ask, how effective is the vaccine? Because personally, I have been vaccinated, but I've heard that the vaccine does not effectively prevent me from getting the COVID again. Therefore, in line with this, how effective is it? And then with new strands coming up due to the mutation, will the vaccine I've taken prevent me from the new strand as well? Thank you.
I would ask, Linda, would you want to respond to the first question? You're active in Nigeria, it's very specific. And I would ask you, Dr. Ramón, if you would respond to the second question. Thank you.
Well, as far as I know, I don't know actually if the vaccines are the same. Honestly, I can't control if the doses are the same that we use and you are in Nigeria. What I sublimed also before is you think always there is something behind it. There is something tricky, something to know that someone is cheating people, and because it comes from abroad, it's something coming from people traveling abroad and so far, or from the government. They say you to be vaccinated. And generally, Africans and Nigerians especially don't like, to follow what comes from this agency, from the government, to say, you must do something now. They think, what's behind it? What was this, the second? There are more epidemics or what? I don't remember.
The second question regarding the efficacy of the vaccines and whether they really do protect one from COVID. Yes. And I asked Dr. Ramón if he would respond to that.
Well, anyway, yes.
Well, from the beginning, we know there are different vaccines. From the beginning, we know that different vaccines coming from different countries who develop them. There's a vaccine from China, there's a vaccine from Russia, there's a vaccine from Pfizer now, let's call, it's many vaccines. And they all say they are different in efficacy and different way, the way they act. We know that. One of them is that, the RNA gets the problem. But the efficacy will change and varies. And that change is the vaccine that we're doing now in the United States today. It's being announced today with the governor, my group. It's being announced. It's the same vaccine from the beginning. Obviously, when you have, this is the virus, who had changed 4 places, and now you still have the same vaccine, who used to be very effective. Now it's less effective, but still, some area hasn't changed, and it will attach the antibody to that and destroy it. But there's not the same efficacy. It happened to all of them, and they go down. This is why I keep saying why they don't release the new one. They have it ready, going with these 4 changes. The efficacy will change, it will be different. And for sure, it will continue to develop the virus, and we have to find a new vaccine like what happened with the flu. Same thing, every year they change. But this one, real, is killing people.
One last question from Mario Paredes at the back, and then we will conclude.
Thank you. My question will be directed to Father Mendoza. In the United States, some of our bishops, they have advocated for the vaccination. But some other bishops, and they are brother bishops, they are all Catholic. They are saying, do not vaccinate. What is the Catholic response?
So I guess I could say that some bishops are not that Catholic than others. Well, I think that we should stress again one big idea. I don't know exactly the basics of their decisions. Those who may not push for vaccination could think that maybe biological health is ordered to spiritual health somehow, and people could be disrupted or could feel that it's against their conscience to use the vaccine for any reason. So there's an order there of the human good. The greatest human good is spiritual, and then it comes the biological good, that is health. But at the same time, as I repeat it again, and as the Congregation of the Doctrine of the Faith is saying, and as the Catholic of the Church is saying, the moral obligation is to take care of your life and health. And you should use the best means for that. If you have better information than the government, if you have more understanding of what's happening, so you could on conscience act against the indications of the legitimate authority. If you don't have more information than the government or better means than the legitimate authority is giving you, then you could fall into an injustice. Now, again, the bishops are they have the responsibility of the moral guiding of their faithful. And it's understandable that they don't decide what to do. They should, as you said well, invite in one direction or others. But at the end, every person should have the decision on their own health and life and on the health and life of their family. And this is very delicate. Dr. Ramón.
A very well-balanced answer there. Thank you.
Say only
I couldn't have done better.
5 seconds.
Dr. Ramón would like to add.
5 seconds, because when I hear Mario saying that, I remember one of my employees saying that they would prefer his fathers to get a natural immunity because people were dying from the vaccine. And I stopped for a second. I said, at that time, 700,000 deaths, million people with sequelae, very sick. And you prefer, because of 5,000 deaths from the vaccine, that they attribute to the vaccine, that immunity? Are we talking about data here? It's 140 to 1, your odds, with a natural immunity.
Something that is also really important here in all this big debate is that it's very hard to make a clear judgment, and that the personal story counts a lot. Because if you have a parent, a relative, someone close who has been very sick, you really want to avoid these problems. If you have seen the virus from very far, you have a very different sensation of what's happening. And then you could see this, maybe doctor can confirm this. If you travel to one country or another, the sensibility is so different. In Europe, we are super protected, in my opinion, about the virus and everything. And I went to Mexico, my homeland, and no one is like, is there a virus? No, well, they were not that worried about it. So it depends a lot on how also the population is living it. But if you have had a story, you would be much more sensitive.
He's one of my favorite saints. His name is St. Thomas. If I do not see, if I do not put my finger in the wound, I will not believe. Pope Francis believes, and in closing vaccines for everyone, I think it's only fitting that we give the last word to him. He continues to speak out boldly and clearly in this regard. On Easter Sunday this year, he said, and I quote, "I urge the entire international community in a spirit of global responsibility to commit to overcoming delays in the distribution of vaccines and to facilitate their distribution, especially in the poorest countries." Once again, a very big thank you to our distinguished panel of guests, Dr. Ramón Tallaj, Dr. Linda Corbi, Dr. Maria Amparo Alonso Escobar, and Father Christian Mendoza for their precious contribution to our discussion. Thanks also to the organizers and sponsors of the event, SOMOS Community Care, Rome Reports, Television News Agency, Harembee Africa, Caritas Internationalis, and the hospitality of the Pontifical University of the Holy Cross. Finally, a reminder that if you missed part of this event, or if you want to share it with your friends, or maybe you just want to watch it again, simply go to the English YouTube channel of Rome Reports. I'm Seàn-Patrick Lovett. Until next time, goodbye and God bless.